The past 2 weeks have focused on understanding the principle of autonomy in its relation to other principles, as well as what the principle implies about informed consent and people's capacities for decision making. For most of you, there is a strong commitment to respecting the decision of the patient, even if you felt, or the medical team felt, that it wasn't truly in the patient's best interest, that it wasn't what beneficence may require. We want to put that commitment to the test this week by focusing in on one of the more controversial issues in medical ethics: what to do with people at the end of their lives. In particular, whether or not hastening death through prescribing a lethal dose of medication or actually administering a lethal dose of medication is compatible with the goals of medicine and the role of the physician. Dax's case gives us a good introduction into this issue. Although his situation was partly a result of a time when physicians took a more paternalistic approach to their interactions with patients, it draws out a lot of the key concepts that still pervade this debate. Dax began his fight for the right to die almost immediately after sustaining severe burns over nearly the entirety of his body. As he recounts the story, "I was burned so severely and in so much pain that I did not want to live even in the early moments following the explosion. A man who heard my shouts for help came running down the road. I asked him for a gun. He said, 'Why?' I said, 'Can't you see I am a dead man? I am going to die anyway. I need to put myself out of this misery.' In a very kind and compassionate, caring way, he said, 'I can't do that.'" What we want to do is pull out of Dax's case a few key issues. First, whether or not asking to die, or being in severe pain, in itself makes one incapable of making decisions for him or herself. Second, if we assume some request to die could be truly autonomous, what such requests require of the medical team. Are they required to help? Are they permitted to help? Or do they merely step away, doing no more than ceasing treatment? Third, and related, is the connection between stopping life-sustaining treatment and actively engaging in the death of a patient. This is often called the killing letting die distinction. Finally, once we analyze these three things, we would also want to ask what is the moral relationship between different ways a physician could be involved in a patient's death, what ties them together, and what may make them morally different. We'll deal with each of these questions throughout the lecture, not necessarily in this order, but all of them come together in many ways as well. So let us begin by linking these issues back up with current established codes of ethics. It is common now to view a patient's right of self-determination as including the right to refuse life-sustaining treatment, both prior to it starting and even once it has started. Recall from the Code of Ethics for Nurses that, quote, "Patients have a moral and legal right to determine what will be done with their own person, including the choice of no treatment, to accept, refuse, or terminate treatment." Dax was deprived of this right, partly due to it not being widely recognized at the time, but this right is also very narrow. It allows patients to request that physicians pull the plug on them, as we sometimes call it. Although for our purposes, we can understand the denial or removal of life-sustaining treatment as passive euthanasia. So there are really two forms that this can take. One, things like do not resuscitate orders, or what are more accurately, do not attempt resuscitation orders, which would obligate a physician not to even start in on whatever life-sustaining treatment or treatments are explicitly forbidden in the order. Such requests can be built into living wills and other advanced directives. Alternatively, after someone has been placed on a ventilator, for example, or some other form of life-sustaining treatment, it may later be determined that the patient no longer wants to be on the ventilator, or shouldn't be on the ventilator, and such life-sustaining treatment is removed, even though it is known that removal of such treatment will result in the person's death. So that is more accurately the pulling the plug, whereas the first one is not even plugging them in the first place. So a patient's right to refuse life-sustaining treatment is widely accepted, but is certainly not without controversy. However, what we want to do is start from this point and explore other ways physicians could be involved in the death of patients and see if the same sorts of justifications we may want to give for passive euthanasia apply to other, more controversial procedures as well. Before examining the arguments, we need to know what the various proposals are and how they are related in a basic sense. The matrix here divides the various proposals up based on certain components. Down the left side you see the connection to the patient's requests. The action is voluntary if the patient has explicitly requested the action, involuntary if the patient has explicitly forbidden the action, and non-voluntary if the wishes of the patient are unknown. It is important to keep non-voluntary and involuntary separate, since no one seriously proposes any sort of involuntary intervention resulting in death, but non-voluntary passive euthanasia, such as removing the nutrition and hydration from someone in a permanent vegetative state, is a current practice, even if somewhat controversial. Along the top, there is a division regarding what exactly the physician does in each case. It is passive if the physician does not administer or removes life-sustaining treatment, but technically something else is the final cause of the death. It is active if the physician actually administers something that results in the patient's death, and it is physician assistance if the physician provides means or information for the patient to self-administer something that results in her death. Given that the patient is the final decider in the case of physician assistance, it doesn't really make any sense to talk about cases of non-voluntary or involuntary physician-assisted dying. Further, the main proposals in favor of greater physician involvement in death are for voluntary physician-assisted dying, or what is also called physician-assisted suicide, or for voluntary active euthanasia, which can be found in the top central box on this matrix. We will be concerned with non-voluntary and involuntary interventions really only insofar as many worry that allowing voluntary forms of euthanasia may lead to these other forms. So we care first and foremost about physician-assisted dying and voluntary active euthanasia. While VAE is illegal throughout the United States, it is legal under strict guidelines in a few countries in Europe, most notably the Netherlands. Physician-assisted dying, on the other hand, is legal in 4 U.S. states: Washington, Oregon, Vermont, and Montana. Again, there are strict guidelines for its use. In particular, a determination by at least 2 independent physicians that the patient is terminal and has about 6 months to live, and that she is capable of making her own decisions. This determination of capacity for decision-making brings us directly into the first question mentioned previously. Does requesting to die, or being in extreme pain, automatically or likely make someone incapable of making decisions? So one concern that can be raised against allowing people to request to die is that such decisions simply are non-autonomous. This can be either because the condition the person is in at the time, such as extreme agony, clouds their ability to decide for themselves, or, on a stronger view, it can be because requests to die in themselves indicate someone is incapable of reasoning properly. The first case, of a patient's condition taking away their autonomy, certainly gains some support from O'Neill's article from last week. Recall that she thinks questions of autonomy and paternalism are especially sharp in the context of medicine because patients regularly have diminished capacity for decision-making. But for her, that often just means their autonomy is partial, not that it is missing. However, as one of Dax's doctors argues in the second video, being in extreme pain itself makes someone, in his words, incompetent. That is why he blew off Dax's requests at first, because Dax was in such extreme pain. So, one may think that such pain counts as an undue influence on one's decision-making, and thus renders the person incapable of making decisions. Conversely, you may think that feeling such pain is essential to truly understanding the decision you are making, and thus if someone else were to make the decision for you, they wouldn't really have all the information. The pain itself is relevant for the decision-making. The stronger argument is that requests to die in themselves show a lack of capacity. As Callahan points out, depression is the single largest contributing factor to thoughts of suicide. And of course, depression is considered a mental illness, and oftentimes someone diagnosed with depression is considered to at least have diminished capacity for decision-making. Thus, if someone expresses a wish to die, according to this argument, it is likely the result of mental instability or other undue influences that therefore make those people incapable of making such decisions for themselves. If this is true, then we would not be respecting the patient's autonomy by helping them die. Rather, we would be murdering somebody. So the argument goes, an appeal to self-determination not only doesn't point in favor of helping patients die, it actually points against helping them. While for some this argument can be quite persuasive, it is difficult to say absolutely that all requests to die are the result of undue influence or mental instability. It is at least possible that there are some cases where wanting one's own death is rational. Or at least we will assume so as we move on, since if this argument is true, then not even passive euthanasia is morally permissible. We will look more closely at the self-determination argument for euthanasia in the next part of the lecture, but I want to end this part by also sketching the other common principle appealed to in the euthanasia debate, beneficence, and also non-maleficence when they are tied together. Like autonomy, as we just saw and will see more in part 2, beneficence is often used by people on both sides of the euthanasia debate to defend their position. In favor of physician-assisted death, or voluntary active euthanasia, some appeal to the suffering of the patient as a reason for the doctor to help hasten death. If a doctor has a duty to do no harm, and a duty to make the patient better off, then leaving her alive when that life is so full of suffering may fail on both counts. Instead, hastening death may be the most beneficent act a physician can do. There are a few concerns with this approach, however. First, this argument on its own does not show why the euthanasia should be voluntary. If a physician has an obligation to relieve pain, or it is true that death can make some patients better off, this could perhaps be true even for people who do not ask to die, or are not currently asking to die. This would seem to give physicians the power to decide what sorts of lives are worth living, an argument Callahan makes in his article. Second, it is unclear exactly where the line is between unbearable suffering, where death would be better, and lesser forms of suffering. Either the physician must make a judgment, which is itself difficult, and again gives the physician the power to decide what sorts of lives are meaningful, or, as Dax himself argues, and Brock agrees in his article, determinations about a person's quality of life and whether their life is worth living should be left wholly up to the person herself to decide. But if this is the case, then what about those people who find even the most common things in life unbearable? How do we distinguish between someone who is generally depressed and therefore would find anything in life unbearable, and someone who would very much like to go on living if it weren't for their particular condition? Finally, as the piece from Keller shows us, it is possible to respond to someone's suffering in a positive way without immediately ending their life. If a physician is supposed to end suffering, she can do so through palliative care as well. While some proponents of euthanasia have pointed out that removing feeding tubes and hydration is an agonizing way for someone to die, thus arguing that active euthanasia would be more humane than passive euthanasia, others have pointed that such a dying process is not painful at all if managed appropriately with pain medication. So if you could just let someone die without intervening, but manage their pain so they're not suffering during the time, this argument doesn't seem to tell you have any additional reason to make their death come faster. For those arguing against physician assistance in dying, they may argue that life is always a benefit to the person who is alive, or that death is always a harm to the person who dies. In either case, a physician's commitment to beneficence and non-maleficence would require her to always keep a person alive, and especially never intentionally cause a patient's death. This is a strong argument, if it is true, but it is very hard to really analyze it closely. It has a problem similar to the beneficence argument in favor of physician assistance. Who gets to determine whether someone's life is a benefit? So, while this argument, and in general arguments from beneficence, are hard to evaluate on this sort of subject, they do point at interesting issues that we can attempt to evaluate. What justifies a physician intervening to help a patient die when she requests it, rather than just sending her home to commit suicide? And, if death is always a harm, so physicians should never cause someone's death, what justifies passive euthanasia? The physician could save the person's life, or keep them alive, but instead does not treat, or removes treatment in those cases. We will look at these questions, which gets into issues of the killing and letting die distinction, and whether or not physicians must do something a patient requests, or risk disrespecting their autonomy in Part 2.